Yeah, good morning, everybody. Today we will be talking about some pupils and pupillary pathways disorders. To start with, we will just have a quick review about the pupillary pathways. Light usually strikes over the retinal surface, over the photoreceptors, to the bipolar cells, to the ganglion cells. These ganglion cells will form the optic nerve. The optic nerve will exit the globe in the crepiform foramen, then it will form the optic nerve till it reaches the optic chiasm. At the optic chiasm, we're going to have a decussation where the temporal fibers will merge with the nasal fibers from the other side to form the optic tract. بعدين هذا الoptic tract بيكمل 95% of the fibers they will go to the lateral geniculate body مشان ما نخربط L light lateral. وبعدين بيعمل هناك ريلي وبيصير بعدين بشكل عندنا اللي هو الاوبتيك radiation which continues to the visual cortex over the occipital lobes. لكن 5% of these fibers they will not go to the lateral geniculate, they will go directly through the pretectal fibers to the pretectal nucleus. From the pretectal nucleus there are going to be fibers that will innervate both the Edinger-Westphal nuclei on both sides. Yani if we go here to the left eye, light will strike, we will have the green light here will form these optic fibers. وبعدين بروحوا على البريتكتال nucleus ومن هناك البريتكتال nucleus it will innervate الإدنجر-وستفال nucleus اللي هي موجودة بالبرين ستيم. الإدنجر-وستفال nucleus هي تشكل الباراسمباثيك component of the oculomotor nerve. بعدين هاي الفايبرز they will continue with the oculomotor nerve fiber in all its pathway till it reaches the inferior branch of the oculomotor nerve اللي هو بيغذي الانفيريور اوبليك والانفيريور ريكتس ماسل. وبعدين هذا البرانش اللي بيغذي الانفيريور اوبليك ماسل فوقيها بصير انه هي السيليري جانجليون، ومن السيليري جانجليون بصير هناك ريلي وبيطلع من عندنا هناك الشورت سيلر نيرفز. هذول الشورت سيلر نيرفز they will innervate the accommodative fibers المسؤولين عن الاكوموديشن بالسيليري body والsphincter pupillary muscle. يعني in conclusion, when we have light strike over any of globes, we will get afferent pathway through the optic nerve and efferent arm through the oculomotor nerve or the parasympathetic components, and the result is going to be meiosis on both sides. The side that get the direct view, direct light, بنسميه احنا direct, and the other eye will consensually be also struck by the pupil for constriction in both pupils when we get the light of any globe. يعني سواء كان اللايت محطوط على اليمين أو على الشمال we will get constriction of both pupils. Also the pupils can be constricted by accommodation. Accommodation centers موجودين بالfrontal lobe. They will go descending also to the pretectal area وبصير في عندنا stimulation برضه للpretectal nucleus وبصير نخش في الباثوي تاع الكونستريكشن. إذا البيوبلز can be constricted by light or by accommodation. الأكوموداتيف فايبرز موجودات more posterior لذلك هم أقل more anterior فلذلك الإكسبوجر تاعهم للتروما أو الانفكشن أقل. Sometimes any lesion might affect the light fibers but they will preserve the accommodative fibers, and we will come later on to this pathway. This is the parasympathetic pathway to the pupils. بالنسبة للsympathetic pathway, sympathetic pathway starts from the hypothalamus. Then we will get a descending fibers through different lateral tracts. بعدين نوصل roots اللي موجودين عندنا احنا طبعا الكرينيو سيرفايكال اللي هو موجود من السيرفايكال والفيرست thoracic vertebrae أو discs. لكن اللي مسؤولين عن الأوكيولار كومبوننتس هم T1 و T2 وهذول برضو كمان بينزلوا الدورزال روت نيرفز. بعدين بيشكلوا الجانجليا اللي هي الانفيريور والميدل والسوبيريور. Majority of the fibers اللي they will supply the ocular structures بيجوا من السوبيريور nucleus of clogget. بعدين بيمشوا مع الكاروتيد fibers مع الكاروتيد vessels. يعني بيدخلوا مرة ثانية على الانتراكرانيال structures through the carotid foramen وبعدين بيكملوا مع البرانشز تاعون الكاروتيد لحديت ما يوصل. بعدين they will go also to the ciliary ganglion لكن they will not make any synapses. They will go directly to the dilator pupillary muscle. فunder the sympathetic effect بيصير عندنا dilatation of pupils. هلا sympathetic fibers, before they go intracranially, they will give some branches to the sweaty glands اللي موجودين على الفيس. فهذه راح نجي لها برضه later on. What's the significance of this pathway? So, in this slide, زي ما شايفين, when we put the light over the right eye, we will get meiosis of both sides. But when we move the light to the left eye, we will get dilatation of both pupils. What do we call this? We call this relative afferent pupillary defect. What do you mean by a relative afferent pupillary defect? Go back here to this slide. If we have any afferent problem on the right eye, if we use a flashing light rapidly moving from the left eye to the right eye. Now, if we put the light in the front of the left eye, the green line means that we have an intact or relatively intact afferent pathway. We will get meiosis on the left and we will get meiosis in the right. Now, if we have any afferent problem anterior to the ganglionic cells in the right eye, if we move the light now from the left eye to the right eye, what we will get? We will lose the stimulatory signal اللي كانت جايتنا من the left side. We will get dilatation of both pupils instead of having constriction of both pupils, and this is, we call it relative afferent pupillary defect. Afferent means in the afferent arm, pupillary pupils, defect, a defect in the afferent arm, and relative, we are comparing one eye to the other eye. حتصير عندنا relative afferent pupillary defect, we should have an optic nerve problem or a major retinal problem زي مثلا central retinal vein occlusion, complete or total retinal detachment. لكن أي lesion anterior للganglionic cells شو ما كانت كبيرة، شو ما كان vitreous hemorrhage dense أو cataract dense, it will not cause a relative afferent pupillary defect. Also, if the lesions were post-lateral geniculate body, any lesion بعد lateral geniculate body, also it will not cause a relative afferent pupillary defect. فإذا relative afferent pupillary defect as a sign, it indicates إنه في عندنا major retinal disease أو optic nerve problem anterior to the lateral geniculate body. Okay. بنسميه احنا paradoxical pupillary reaction. Instead of having a constriction to the light, we will get dilatation. It's not a dilatation, simply it is loss of the stimulatory signal اللي كانت جايتنا from the other side. We'll talk about some disorders of the pupil as an ocular causes that might cause an abnormal pupil shape, pathologies or disorders that affect the neurological pathways, and some drugs that might affect also the pupil reactions and shape. Usually the pupils are round, they are usually regular, they are usually equal in both eyes. Sometimes we accept a difference in the pupil size, about 2 millimeters difference, in the absence of all other abnormalities, what we call it anisocoria, anisocoria. The pupil size is not equal in both sides, and usually the pupils are reactive to light and accommodation. فهي الأشياء, when we examine any pupil, we should concentrate on it. Okay. Ocular causes that might cause an abnormal pupil shape or reaction. Sometimes we have an ocular inflammation that will cause posterosynechic adhesions between the posterior iris surface and the anterior lens capsule. It can cause any shape for the pupil. Sometimes post-ocular surgery, we might have abnormality in the pupil shape. Post-trauma, so sometimes the pupil shape will be changed, or sometimes we will get mydriasis post-trauma due to the rupture of the sphincteric muscles. In this picture, this is a color photograph showing the anterior segment of the eye. The cornea is transparent, so we're not seeing it, but here the pupil, we have posterior synechic adhesions ما بين iris and the anterior lens capsule, so the pupil shape is not anymore round. We have different shape. It has a clover leaf appearance due to these posterior synechic. In this picture, we have traumatic iridodylisis. The iris is not attached on this side, so the pupil got a D-shaped pupil. The pupil shape is not regular, is not round, it is D-shaped. In this, we have what we call peaked pupil. Okay, there is on this side here superinasally we have a injury, full thickness injury, so the uveal tissue, the iris tissue has penetrated through it, so we get this abnormal pupil shape. So we can get abnormal pupil due to ocular causes as you are seeing here. Now, what can cause some other disorders for pupil? A disorder that will interfere with the sympathetic or the parasympathetic nerve supply. Sometimes we see this in a Horner syndrome, Adie's pupil, Argyl Robertson pupil, and pupils defects due to the midbrain lesions as a paranoid syndrome, as we will see later. The Horner syndrome. As we have seen, the sympathetic pathway is a very long pathway, starting from the intracranial, then go downward, then go directly in the neck, then go backward, combining the carotid within its long pathway, intracranially in the cavernous sinus. So we have a very, very long pathway for the sympathetic. Any affection of this pathway during this large root will cause interruption of the sympathetic pathway. What we will get, what we call it, Horner syndrome. So, the Horner syndrome, the main signs of it, the normal pupil usually is midriatic in relatively dark condition, myosed in light conditions. Any pupil that does not follow this normal physiological reaction is usually the abnormal pupil. So, in Horner syndrome, what we are going to get, these are possible causes, okay, for it: intracranial trauma, tumors, hemorrhages, the pathway, syringomyelia, which is the dilatation of the spinal cord cavity, sometimes might be associated with medulla involvement, so it might cause also upper limb muscle wasting, lung apex tumor, neck trauma, neck injuries, cavernous sinus disease. Sometimes we have something we call congenital Horner syndrome, which might be associated with heterochromia iridis, difference in the iris colors between the two eyes because of the neurotrophic function of the sympathetic pathway. So these iris pigments will not develop properly. This is a chest X-ray showing opacities in the superior lobes here of the lung. So this also can cause a Horner syndrome. We have two stable signs that are always present in the Horner syndrome, which is meiosis. It's a small pupil in the affected side, which is more prominent in the dark. In the dark, usually both pupils, they will get a little bit dilated. And usually have a mild ptosis because of the affection of the molar muscle, which is supplied by a sympathetic pathway. Now, the anhidrosis, which is the absence or the decreased sweating on that side, depend على الليجن وين صارت. إذا صارت pre-genicular, يعني صار الليجن before the sympathetic that's accompanying the carotid gets again to the intracranial structures, we will get decreased sweating, الانهيدروز. بس إذا الليجن كانت صارت after the sympathetic go inside through the carotid foramen, for example, cavernous sinus problem, any trauma after that, we will get no anhidrosis. الانوفثالموس كانوا ايام زمان يحكوا عنه, بس it's actually an apparent enophthalmos due to the ptosis that accompany the Horner syndrome. فاذا the two stable signs اللي بنشوفهم هم meiosis والmild ptosis. Okay. In this picture, this is a color photograph showing both eyes. As we can see in the left eye, we have relatively smaller pupil size in comparison to the right eye, and we have an increase in the lid decrease. Tomorrow, inshallah, Dr. Khalid will be talking about ptosis, so we'll see this is one of the signs of ptosis that is apparent here, which is usually mild. It is not covering, for example, the complete pupil axis, so this is also another sign of Horner syndrome. In this picture, on the right side, we will have a small pupil, on the left side, large pupil. Also, there is a different in the iris colors, what we call it heterochromia iridis. This is also a sign of congenital Horner syndrome. Light near dissociation. What do you mean by light near dissociation? As we have talked before, the pupils can be myosed either by accommodation, which is near apprehension, or light. So these lesions, they are a defective light pupillar reflex, okay? The pupils are not anymore reactive to the light, but they can be constricted by accommodation. There is no condition that can cause the opposite thing, which means the loss of accommodation and preservation of the light, as we have said, because of the location of the accommodative fibers. They are usually more resistant to trauma or infections. Causes that might cause light near dissociation ممكن يكون ان احنا diabetes mellitus, multiple sclerosis, periaqueductal brainstem lesions. يعني a lesion that will affect the connection area between the light connection fibers and the pretectal nucleus and the accommodative fibers and the pretectal nucleus. Here, there is no reaction to light. When the patient starts to accommodate, شو اللي بيدلنا على انه كان بيعمل accommodation وبصير عندنا convergence. والconvergence هو جزء من التريات تاع accommodation. As we can see, both pupils they start to be meiosed. Now, the speed of this meiosis will depend on the type of the lesion that we will discuss later. Okay. So, a relative afferent pupillary defects, an afferent pathway problem. Usually, in those patients, we have equal pupils in the normal. There is an intact nerve reflex, and the causes of these can be an optic nerve problem or major retinal disease, as we have said. But any lesion, even dense vitreous hemorrhage, dense cataract, or any lesion post-lateral jugular body, they will not cause a relative afferent pupillary defect. Adie's pupil. Adie's pupil usually caused by a ciliary ganglionitis, usually post-viral. This will lead to the loss of the parasympathetic fibers that are completely for the light and here. Then this will be followed by re-innervation. And the fibers that they will take over are usually the fibers that are responsible for accommodation. This will cause anisocoria, different in size of both pupils. Usually it is more common in females and usually common also in young patients. فإذا هذول الناس بيجوا في accommodative problems in the beginnings. Usually these ladies present with complaint of poor accommodative, especially when they are changed from far to near. Especially students, university student, they cannot write well. They complain about accommodations. Then usually the accommodative problem or presbyopia, as we have seen, this is the disorder or a complaint of relatively elderly. But هنا they will have a young patient who is complaining about reading problems. So this should ring a bell, and we should have a problem related to accommodation. Usually, we are losing the parasympathetic. So the pupillary findings will be, we'll have a large pupil that will keep on being large in light. Usually, زي ما حكينا البيوبل إذا تعرضوا ل strong light, they will be meiosed on both sides. We will have poor reaction to light. They will not be meiosed with light, but we will have a slow and sustained meiosis when the patients complain when he attain accommodation. This is why they are complaining about reading problems. They have slow and sustained meiosis and accommodation in comparison to the normal scenario. Usually, if we examine the patient on a slit lamp, we will see a vermiform movement of the iris, which can be seen on the slit lamp. وهذه سببها اللي هي localized accumulation of the parasympathetic neurotransmitter who acetylcholine at a certain sites of the pupil margin. فبصير في عندنا localized contraction, then relaxation, then the neighboring side بصير في relaxation, and this will follow as will make like a Mexican wave, like as if we are seeing a worm moving in the pupillary margin. These pupils are usually super sensitive to a small concentration of the pilocarpine, 1/1000. Usually, if we use even 1%, sometimes we will get no effect of the pilocarpine. But in these patients, usually we have a brisk constriction of the pupils in response to a diluted pilocarpine. والسبب تبعها إنه بصير في عندنا إحنا upregulation of the postsynaptic receptors للacetylcholine. Okay, فبصير في عندنا higher number of postsynaptic receptors. فبصير even a small concentration of pilocarpine can cause a brisk meiosis. So على السليت لامب ممكن نشوف احنا vermiform movement انه a localized action potential, localized contraction of the pupil. Okay, بينما ال other sides. فإذا this is a dilated pupil with vermiform movement at the pupillary margin. Okay. These signs اللي حكينا عنهم, these are signs of acute Adie's pupil. Acute Adie's pupil. Usually, the chronic Adie's are small pupils they are non-reactive لا لللايت ولا الاكوموديشن فبيسموه old little AD. بس احنا عادة بنجيب الاسئله على الاكيوت ADs لانه it's more prone. الارجل روبرتسون pupil usually they have a bilateral small pupils. It is related mainly to tertiary syphilis and neurosyphilis, where we're going to have the loss of fibers, okay, at the midbrain due to the infection by the syphilis. We'll have loss of light responses and intact accommodation, but the accommodation and the light response here, it's quick in comparison to the AD's pupil. Okay, فالADs بيكونوا slow and sustained بينما هون البيوبلز بيكونوا زي ما حكينا they are usually small pupils and we do not have light accommodation light reflex بينما accommodation reflex is going to be quick. Okay, because of the neurotrophic functions we will get a feathery appearance of the iris stroma. إذا iris stroma usually إذا نطلع عليها على السلت لامب فيها details فيها stroma فيها depressed areas elevated areas. This appearance of the iris will be lost فبصير كأننا نطلع على طرف feather. It is architecture details تاعت الايرس will be lost because of the neurotrophic functions. الميد brain lesions زي ما حكينا هاي المنطقة اللي بصير فيها الوصلة ما بين الاccommodative والlight fibers. ف if we have any CVA, any demyelinating lesions, any infection at this area, this will lead to also to a light near dissociation. Okay, فهاي إذا lesions in the pretectal and nuclear complex will disturb the retinocortical fibers اللي هم الفايبرز اللي من الريتنا على الكورتكس, but they will preserve the accommodative fibers. It can be seen sometimes in different type of lesions. واحد منهم البارينويد syndrome. طيب, other causes that may give us an abnormal pupil, patients who are in coma, depending على type of coma, but usually pupils are dilated إذا ما كانت الكوما مش related to certain toxins, certain drugs, وcranial nerve oculomotor cranial nerve pulses ممكن تؤدي برضو إلى abnormal pupil shape. الدراجز يعني إذا لقينا إحنا البيوبل دايليتد لأي سبب من الأسباب بدنا نحط في بالنا أسباب بسيطة بعض المرات إنه المريض ماخذ قطرة ماخذ أدوية في certain drugs that contains parasympathomimetic أو sympathomimetic that will cause an abnormal pupil shape. For example إذا المريض كان مر على عيادة عيون محطوط له قطرة توسيع تروبيكامايد أو سايكلوبنتوليت أو أتروبين. الأتروبين سواء كانت قطرة أو systematic they might cause also dilatation. الألفا ريسبتورز أجونست زي الفينيلفرين والأدرينالينز واللي هم موجودة في كثير من الأدوية و sometimes even السيستماتيك combination. Muscarinic agents زي البايلوكاربين they will cause constriction. systematic drugs زي الأدرينالين المورفين الويدز كل هاي الأشياء ممكن تؤدي إلى abnormal pupil shape. فإذا هاي الأشياء بنحطها في بالنا when we get an abnormal pupil shape. By this we conclude the shape and the reactions of the pupil, and we will go to a very common presentation نحن بنسميه optic nerve head swellings. It can happen in response to many ocular and systemic disorders, although we have different and variable causes, but almost the appearance is comparable between these lesions. خلينا نطلع على الصورة هاي. هنا in the upper right here we have usually the normal disc that we see. Usually we have a clear and distinct neuroretinal rim. We can differentiate the retina from the pupilla, which is the nerve fibers. We have usually small telangiectatic blood vessels on the surface, and the cup is easily appreciated here. This is the normal appearance, relatively normal appearance. Now, if we see this picture, we have an optic nerve swelling. This is the pinkish site here, which is the normal or this relatively size of the optic disc, but all this area around it from the retina has been swollen. So, and the neuroretinal rim is not that distinct. So this is a swollen optic disc. إذا حكينا pupil edema معناته إحنا we are saying that the swollen optic disc is resulting from elevated intracranial pressure. So we'll use the term swollen optic disc until we are sure about the cause of this swelling. Causes are variable. We will talk about some also causes in this lecture. High intracranial pressure, a space occupying lesion, inflammations, demyelinations, papillitis, malignant hypertension, ischemia that will cause that will affect the blood vessels supplying the optic nerve. central retinal vein occlusion, and this type of optic nerve swelling, we call it the central retinal vein occlusion, whereas the optic nerve is going to be swollen. Differential diagnosis. Not every swollen disc or abnormal pupil or optic disc shape is pupil edema or elevated interior pressure or a real swelling. Sometimes we get a hypermetropic disc because of the small size of the eye. We will get the same number of fibers that will go through the smaller opening. The appearance of the disc will appear as if it's a swollen and elevated disc, but in the absence of all other signs, this is, we call it hypermetropic disc. It is in the hypermetropia, small eye, بيكون الدisc large, elevated a little bit, but no other signs of elevated intracranial pressure. Sometimes we have a hyaline material deposited in the disc body itself, بنسميه احنا optic nerve drusen، وهذول الهايلاين material بيغيروا شكل الديسك وبيبين كأنه swollen, but the other signs they are not there. فthen optic nerve swelling. Myelinated nerve fibers. Usually optic nerve gain myelin after it exits from the cribriform plate of the sclera. لكن sometimes the myelin sheath extends intraocularly فبيبين هذا المنظر فبصير الديسك sometimes this is even a whitish changes in the ganglionic layer because of myelination فبكون برضو شكل الديسك مش easy to judge if it's swollen or not. Sometimes في عنا dysplasia, the complete disc has not formed well, so we cannot judge also the pupil edema easily. We'll start by the high intracranial pressure. How do they present? These patients present usually with obscuration of vision that is transient in the beginnings. They do not have acute loss of vision, okay? They describe sometimes change in the visual acuity when they are moving, when they change their position. These signs does not continue for a long time, and they are not acute. They will present with progressive sometimes changes. They describe a headache that is really worse in awakening and also aggravated by coughing and elevated intra-abdominal pressure. They might present with nausea, retching. They might present with diplopia. Why? Sometimes the sixth cranial nerve, abductor nerve may get palsy or compression. They might complain about diplopia. The sixth cranial nerve has the longest path, and usually it is the thinnest intracranially, it might be involved with elevated intracranial pressure. Sometimes إذا كان في سبب للelevated intracranial pressure, we will get a focal neurological symptoms مثلا paralysis على side, hemiplegia on the other side. كل هاي الأشياء ممكن تساعدنا to diagnose it. History of infection, history of trauma, that will give us a hint. Why do we have elevated intracranial pressure? Now, these are the symptoms and the parts of the history. Now, what are the signs that we can see? Vision in the early phases زي ما حكينا is not going to be affected, but later on the patient might describe affection in his or her vision. Now, swollen optic disc. يعني anterior segment most of the time we will see nothing unless there is a special cause. يعني بطلنا نحكي عن primary elevated intracranial pressure. لما نطلع على posterior segment we will see a swollen optic disc زي ما شفنا بالصورة with a loss of margins, details, prominent capillaries and absent venous pulsation. شو معنات venous pulsation? Usually the central retinal vein, it fills with blood. Then to reach a certain limit, which is usually higher than the intracranial pressure, then it will make a pulse. فإذا كان venous pulsation أعلى من intracranial pulsation, معناته we can see this venous pulsation. If we get an absent venous pulsation, which happens in around 80% of the elevated intracranial pressure, معناته احنا في عنا elevated intracranial pressure. لكن normally في عنا حوالي 5 to 20% of the normal population, they have a continuous flow of venous return. يعني ما بيكون في عندهم venous pulsation normally. If we see the venous pulsation, we can rule out the presence of elevated ICP. لكن إذا ما شفنا the venous pulsation, بدنا نشك إنه this could be normal for the normal population or could be due to the elevated intracranial pressure in addition to the other signs. Usually إذا عملنا المرضى visual field, they will get a large blind spot. The blind spot in the visual field represents the optic nerve location فإذا كانت الأوبتيك نيرف swollen, this area will be larger on the visual field. أو ممكن later on إذا صار في عندنا chronic papillary edema ال visual field completely will be constricted. وممكن نلاقي زي ما حكينا signs of space occupying lesions زي ما حكينا paraplegia, hemiplegia أو other signs. In this picture we see usually this is the right and the left eye. زي ما احنا شايفين هاي المنطقة اللي هي لونها yellowish المفروض this is the size and the site of the optic nerve بس بنلاحظ كل الريتنا اللي around it has been swollen. In your retinal rim is not distinct. We cannot say that the retina or the pupil, the papilla of the optic nerve has ended here. So this is a swollen optic disc. And on the other side, this is a swollen optic disc. Usually it is bilateral, but not necessarily symmetrical بالنسبة للoptic nerve swelling بالelevated intracranial pressure. What are the investigations? Usually زي ما حكينا الهيستوري تاعهم is suggestive لكن they need a brain imaging to rule out secondary causes. MRI, MRV, sometimes CT brain, and if all these they need also another investigations like complete blood count, vitamin D, vitamin B12 assessment. كل هاي الأشياء لها association مع elevated intracranial pressure. Sometimes of these prove to be normal. Nothing weird. We can refer these patients to a neurologist or a neurosurgeon to check for the lumbar puncture direct measurement of the intracranial pressure, which is usually between 8 and 25. If we get a higher opening pressure, we call it higher opening pressure in association with the other symptoms and signs, we make this diagnosis. So usually a rule of ophthalmology sometimes to diagnose, to refer, and to follow up this swollen optic disc. The treatment usually أيام زمان كانوا يسموها benign elevated intracranial pressure, but it's not anymore benign because if left untreated, it will cause loss of vision, loss of hearing, loss of other sensations because of the elevated intracranial pressure. فناو احنا بنسميها idiopathic elevated intracranial pressure that do not have found another causes to explain why do we have this elevated intracranial pressure. فالهدف إذن to decrease the CSF production by medications or to increase the drainage of the CSF. The medications زي acetazolamide will decrease the production of the CSF from the choroidal plexuses. Sometimes if there's a failure of treatment, neurosurgeons بيروحوا لها ventriculoperitoneal shunts. ممكن يعملوا sometimes إذا كانت المريض حالته ما بتساعد ممكن نعمل شيء بسموه optic nerve fenestration. نعمل openings small openings بالمننجيز اللي around الأوبتيك نيرف لحد ما تتحسن حالة المريض اللي نقدر نعمل له proper assessment. فالهدف إذن to decrease the intracranial pressure around the optic nerve بالنسبة للأوبتيك nerve fenestration. Optic neuritis. It's either inflammation or demyelination of the optic nerve that will result in affection of the optic nerve functions. It can be in the form of papillitis, means that the inflammation or the ischemia or the infection has involved the anterior, the visible part of the optic nerve, which is the papilla, or it could be retrobulbar. That means the infection or inflammation has affected the part of the optic nerve posterior to the sclera, which is not visible directly by ophthalmoscope. Simply, الأوبتيك نيرف في كومبوننت بتكون intraocular اللي بنقدر نشوفها اللي هي البابيلا وفي جزء منه بيكون retrobulbar. فإذا كانت الإسكيميا أو الانفلاميشن أو demyelination affected the anterior part, we will see the optic nerve swelling directly. لكن sometimes we will get a retrobulbar inflammation. Okay, retrobulbar ischemia isn't the normal appearance of the disc, but there is loss of functions, as we will see later on. Usually, optic neuritis, the patients present with acute loss of vision that might progress over a few days, then it slowly improves. بالنسبة للإيديوباثيك type. Usually they describe a pain upon eye movements. السبب إنه الأوبتيك nerve it passes through the common tendinous range of the forerecti muscle وأقرب ما يمكن بيكون باتجاه الميديال rectus. فهذول البيشنتس usually هذول females they describe an aggravation of this dull achy retroglobe pain, especially when they attempt to do an adduction, when they medially rotate the affected eye. Patients might describe also history of viral infections. إذا كان السبب مثلا multiple sclerosis as a degenerative demyelinating disease ممكن يكون عندهم another signs غير الأوبتيك neuritis مثلا diplopia, other involvement للbrain structures by the demyelination. This is an MRI, high brain MRI showing both optic nerves زي ما احنا شايفين على right side hyperintense changes in the optic nerve in the right eye. Okay. ممكن البرين MRI تبين لنا another يعني why do we have this optic neuritis زي مثلا very common cause ان احنا multiple sclerosis. These are multiple periventricular lesions اكبر من 5 ملم بنشوفهم على more than one level. فهاي الكرايتيريا اكيد اخذتوها بالنيورولوجي how to diagnose it. مثلا هون بنشوف الليجنز بالسيربيلم واذا لقيناها بالسباينال كورد زي ما في الصوره هون معناته this is more likely to be a multiple sclerosis as the cause of this optic neuritis. By examination, usually they have reduced optic nerve function, which are the visual acuity, the color vision, and the visual field, and the increase in the blind spot area over the visual field. And sometimes we do not see anything. We see in the retrobulbar neuritis, we can see normal optic disc, but the physician can elicit a relative afferent pupillary defect, which is a very important sign to diagnose optic neuritis. إذن swollen optic disc not necessarily to be there، لكن احنا بنشوفه بالpapillitis وممكن نشوفه normal الديسك إذا كانت optic neuritis is retrobulbar. المانجمنت for these patients هلا الاسوسيشن ما بين الاوبتيك neuritis والمالتيبل سكلروسيس is really high. حوالي 25% of the multiple sclerosis بيكون الفيرست presentation لهم بيكون optic neuritis. اوكي فالفيرست attack of optic neuritis not necessarily to diagnose multiple sclerosis لكن في high association ما بين المالتيبل sclerosis والاوبتيك neuritis. Usually إذا كان السبب مش multiple sclerosis we need to target our treatment to that site, viral infection أو إذا كان سببنا other side toxins كل أشياء we need to treat it first. Usually إذا كان السبب أن احنا demyelinating يعني association مع multiple sclerosis بيكون عندنا الستيرويدز that can help our patient to speed up the resolution phase لكنها عادة ما بتأثر على الفاينل prognosis. هلا طبعا في another immunomodulating agents زي الimmunoglobulins وال other agents that are used also to treat the patients of multiple sclerosis. The prognosis of optic neuritis is variable. Mostly the vision will recover slowly, but some of the other optic nerve functions, زي color contrast sensitivity and the color vision, unfortunately they will be affected permanently. يعني المريض ممكن يرجع يتحسن نظره ل 6/6 لكن الcolor والcontrast sensitivity they will be affected. And sometimes the patients presented with no light perception visual acuity and with management or sometimes even with only just observation they recover a 6/6 vision بالنسبة للسنيلن acuity لكن the other functions they will be affected. Sometimes unfortunately the visual loss will be permanent and usually with the recurrent attacks of the optic neuritis we will get a cumulative damage over the optic nerve functions. So the optic nerve is supplied by a blood vessels وهذول blood vessels ممكن يصير فيهم ischemia وهي الإسكيميا ممكن to affect the anterior part or the visible part of these blood vessels or the retrobulbar parts that also supply the optic nerve. فإذا الأوبتيك nerve بيغذي blood vessels وهذول blood vessels they might be compromised وهذه compromised ممكن تكون نتيجة ischemia نتيجة inflammation نسميها arteritis أو ممكن تكون non-arteritic ischemia that will close these small blood vessels that supply the optic nerve. So لما نحكي عن ischemic optic neuropathy معناته there is closure, there is ischemia of these blood vessels either arteritic or non-arteritic because of the compromisation of these blood vessels that supply the optic nerve. So usually these patients إذا بصير عندنا إحنا optic nerve ischemia فبصير عندنا sudden loss of vision or visual field defects وعادة بتكون altitudinal pattern يعني المريض بوصف إنه ما بشوفش الجزء العلوي أو الجزء السفلي من الصورة كاملة. Okay. usually they describe احنا هون عم نحكي عن مثلا one entity that might cause degeneration اللي هي giant cell arteritis. ممكن المريض يجي يشكي من pain or scalp tenderness. Usually the sudden or loss of vision, this patient describe it in the morning because usually the blood supply decreases during sleep, في an acute loss of vision in these patients. Okay. رح نحكي على entity بتعمل degeneration, arteritic type that will cause ischemia to the small blood vessels اللي بيغذوا الأوبتيك nerve. Giant cell arteritis, it's an autoimmune disease. It's usually occurring in elderly patients over the age of 60. It has a predilection for a special type of blood vessels, the medium-sized to large-sized artery vessels, especially with these vessels with the internal elastic lamina. Usually they present with sudden loss of vision, scalp tenderness, jaw claudication. They have some achy pain due to the affection of the masseter muscles. They describe shoulder pain. The elderly female cannot compare hair, for example, and they might have a constitutional symptoms like malaise, fever, and a dull achy pain with their muscles because there is a high associations between the polymyalgia rheumatica and the giant cell arteritis. Signs, we might elicit a decrease in the visual acuity. The patient might, we might get also a visual field defects, typically in the lower half, زي ما حكينا altitudinal, because usually the upper parts of the optic nerve fibers are going to be affected by this ischemia. Swollen, choky, pale disc with a hemorrhagic disc, we can see it, but the retina and the blood vessels, they are normal. Usually, discs are smaller in size than normal if we compare it with the fellow eye, and we might elicit tenderness على temporal artery area. So this is a color fundus photograph showing a swollen optic disc. إذن neuroretinal rim is not distinct with hemorrhages. With a history of sudden loss of vision, we should think about in an elderly patient of this entity, اللي هي giant cell arteritis. This is also a swollen or enlarged superficial temporal artery. والpatient ممكن describe pain tenderness فيها أو إحنا we might elicit tenderness. Okay, this is the histological appearance. Usually the blood vessels اليوم بتاعهم are large with internal elastic lamina وهي الادفنتيشال surface muscles. بينما هذول الناس usually they have a giant cell arteritis زي ما احنا شايفين بالسهم الاخضر هون. These are giant cell granulomas. فالwall is infiltrated by giant cells granulomas. Lumen is very small. The wall is also infiltrated by a chronic type of inflammatory cells, T cell inflammation. Investigations. These patients with suspected elderly patient with suspected giant cell arteritis should have an ESR and C-reactive protein assessment. The ESR usually is high in the range of 60s or higher, although some patients around less than 20%, they might have even less than normal ESR. But we need to keep it in mind always if it's high. C-reactive protein is more associated with active inflammation in these cases. And we should arrange for these patients a temporal artery biopsy. And we should keep in mind the nature of this disease, that not the whole length of the artery might be involved. لذلك احنا بدنا نعمل biopsy. We should talk to our pathologist. We are suspecting a giant cell arteritis, and our pathologist should do a serial cut for the whole biopsy, not just a specific cuts, serial cut. The whole sample should be cut. And to be more sure, we need to have at least 1 inch, 2.5 centimeters of the superficial temporal artery as a biopsy to increase the chance of yielding a positive biopsy. If we also get a negative biopsy from the ipsilateral side, we need to go to the other side to have this biopsy. Why do we need to have a biopsy and we need to make sure of our diagnosis? Because these patients need a long life immunomodulating agents, steroids. These patients are elderly with diabetes, hypertension, osteoporosis. Steroids are not risk-free treatment for these patients. So we need to make sure. Now, for other, for example, Doppler Doppler ultrasound for the superficial temporal artery will show also an increased hypoechogenic hues around the optic nerve or around the temporal artery, which might help us also in the diagnosis. But the temporal artery was still mandatory if we are suspecting these patients. بالنسبة هذا لما نكون متوقعين في عندنا arteritic type of ischemia to the optic nerve. In the non-arteritic type also complete blood count rule out the anemia, blood pressure usually they are hypotensive. Diabetic patients also might present with diabetic papillopathy, and the cause of ischemia, the cause of these vasculopathy, occlusive vasculopathies could be also diabetic, بالإضافة للautoimmune work up and rheumatological work up complete. حتى أيام زمان يعني من أيام زمان كانوا حتى يشخصوا intelligent cell arteritis not necessarily to have all of them positive, you need to have at least 3 out of these 5. إنه الage لازم يكون elderly. يكون في عنده new recent of headache, temporal artery يكون tender to palpation أو decreased pulsation, which is usually normally we can feel the pulsations. ESR يكون in the range of 50. Okay, والبيوبسي تكون abnormal. بس زي ما حكينا not necessarily نكون البيوبسي abnormal. يعني الكلينيكال scenario with 3 out of these 5 is enough to have our diagnosis of giant cell arteritis. Why do we need to treat giant cell arteritis? Sometimes the loss of vision is permanent in the affected eye, but the fellow eye can be affected soon within sometimes a few weeks in this patient. And also the giant cell arteritis will affect other vascular parts. For example, the carotids. It might affect the coronary arteries. It might affect the posterior basilar arteries. It might affect also the aorta, causing dissection. So these patients might die because of systematic complication of the giant cell arteritis. So we need to make sure of our diagnosis. And we need also these patients to be followed up by our medical colleagues. Okay. Unfortunately for the non-arteritic type, there is no treatment available unless we control the underlying diabetes, hypertension, and the anemia can help us. The prognosis, the visual loss is usually permanent بالنسبة للgiant cell arteritis, although some very minor reported cases that they gain vision, but depending على the level of the ischemia, the fellow eye can be affected. لذلك we need to start our steroid treatment as soon as possible. طبعا الsteroid starting of a treatment does not mandate that we need to do a temporal artery biopsy. We need, yes, to manage to do or to arrange our temporal artery biopsy as soon as possible. لكن في عندنا window period حوالي 10 days ل 2 weeks لحديت ما تبلش تصير الانفلاماتوري تشينجز اللي بنشوفها على الهيستولوجي تتغير بالستيرويدز. فإذا with high suspicion we start our patient على high dose of immunomodulating agents, then we arrange our temporal artery biopsy. فإذا we start steroids as soon on the same day that we are suspecting our diagnosis. بالنسبة للnon-arteritic type, the rate also of the fellow eye involvement is high, around 40–50%, although we do not have a real treatment for these patients. Optic atrophy هو the last appearance that we are losing the optic nerve fibers. فبكون احنا زي ما كنا متعودين على نوع الاوبتيك نيرف as a little bit pinkish. فالسبب يعني هذا الاوبتيك نيرف هيد بنصير نشوفهم very white, okay, very bright white. السبب ممكن تكون pale أو ممكن تكون زي ما شفنا بالجلوكوما also the optic disc might be cupped. يعني we are losing the fibers فبكون large cup volume is apparent. أو ممكن يكون optic atrophy يعني السايز تبعه بظل ثابت الكب لكن الاوبتيك نيرف فايبرز are lost in the optic nerve fibers. ممكن تكون نتيجة compression أو end result of ischemic optic neuropathy لكافة الكوز اللي حكيناها, glaucoma, optic neuritis, inherited diseases, drugs, special toxins, tobacco, alcohol, special الميثانول, mixed types, vitamin B12, vitamin D deficiency, كلياتهم ممكن يؤدوا إلى optic nerve atrophy. And thank you everybody. يعطيكم العافية.
أشكرك دكتور فواز، شكرا جزيلا.
الله يعطيك العافية.
الله يعطيك العافية دكتور فواز.
الله